Hello, this is Putting It Together Module 2. So, physical examination, and you want to be as well organized as you can when you do this. Remember, when our last module we talked about that whenever people are seeing you, that you're on stage. Think of yourself as being on stage. And if you're not well organized, you're going to have to leave the room, go get things. You're going to, appear to be, whether you're competent to do the assessment or not, you're going to appear to be incompetent. People will pick up on it. They lose confidence in you. And that kind of gets reflected back. They challenge you, and you lose confidence in yourself, and it's like a vicious circle. So you want to spend a little bit of time preparing the physical setting. For example, if you know you're getting a new patient, make sure that the room is ready for a new patient. If you know you're going to be assessing, doing a partial ongoing assessment on your patient, make sure you have your stethoscope. Make sure you have your equipment for doing vital signs at hand. Make sure you have all tongue blade if you're going to use a tongue blade. Whatever equipment you're going to have, you want to have that and have that organized. You also will want to prepare yourself. For example, maybe you know you're going to assess an alcoholic and you have just a bad feeling about it. And you start reflecting, why do I have this bad feeling? Oh, well, my father's an alcoholic, and it brings out the feelings I have for my father. I don't guarantee that it'll make it easier when you reflect like that, but I think that knowledge is going to be helpful in some way. It may still be hard to do it, but as they say, forewarned is forearmed. Patient positions. A lot of time, now in the textbook we have all these ideal positions that you want to have certain things where the patient is lying, certain things where the patient's sitting up. There are plenty of patients that you aren't going to be able to do all those things. You may have to turn them on their side instead of sitting them up. And even if you are able to get them into all those positions, take advantage of the positions you find them in. Like if you go in and they're walking back from the bathroom to their bed, why then take that time to assess their gait, and then when they sit down, do the things you want to do with them sitting first, and then when they lay down, rather than having them doing a lot of position changes. Because even if they are able to get into all the positions, they may not be cooperative. They may not be able to have the stamina to do all the things you want them to do. So take advantage of where they are when they're there. Now, our 4 basic exam techniques are inspection, palpation, percussion, and auscultation. Remember, we have 2 different types of palpation, light and deep. Nurses typically just do the light, although you certainly can do deep palpation, but nurses typically don't do a lot of deep palpation. Percussion, remember, that's not just about sound. We have several types of percussion too. We've got direct and indirect, meaning are you percussing directly on the person's body, or do you have your another finger between, or something else between the part you're percussing with and their body? And then blunt percussion, remember, that's where you use the back of your fist against somebody's kidney area, and you're not even looking for sound there, you're just looking for pain. But most of the time percussion is about sound. So you need to train your ear. You need to start training your ear. One way to do that is look out for those people that have unusual, that you know you're going to have unusual findings. Like, for example, if you have a patient with ascites is a collection, edema basically, but in the abdomen. It's a collection of fluid in the abdomen. So you would expect that person to have dullness when you percuss over their abdomen. So percuss over their abdomen and then compare it with your other patient that you know is distended with a lot of air, or somebody else that's not distended at all. Compare those things. Similarly, with auscultation, if you have a respiratory therapist that has a lot of experience and you see her coming out of your patient's room, ask her, what did you hear? And then you go in and try to hear those same sounds. Now, that's not to say there could be a difference. Maybe she could be wrong about something. It's more likely you're wrong than she's wrong if she's had a lot of experience, but still she could be wrong. So don't just, like, if there's a discrepancy, why, keep with it. Another thing, patients can change in a heartbeat too. So just because maybe she heard coarse crackles and then that was before her treatment, so that's not a guaranteed. I mean, don't, if you honestly don't hear what she's heard, why don't just say, oh well, it must be coarse crackles because she said it was. No, don't that. I don't want you to get that idea. Mental status. Now this is usually something you're going to start to assess right away. When you first go into the room and you greet the patient, you're going to get some idea about how alert they are, their level of alertness. And even if, let's say, you had to speak to them 2 or 3 times before they pay attention, and then you do your mental status exam, they're totally oriented, but when you leave, they're drift off again. Well, something's going on there. They may be oriented, but there's something going on with their level of alertness. Executive function relates to if they're able to carry out tasks in a logical way. Like if you give them some simple instructions, are they able to do it or not? Do a simple task. And then judgment. A lot of times judgment deficits you're not going to notice during your assessment necessarily. You might notice them. You can certainly ask them, what would you do if, and then see if that makes sense what they answer. But a lot of times you'll pick up on judgment issues when they do bizarre things, and then you ask them about it and they just act like it was a perfectly reasonable thing to do. And then memory. We've already talked about ways to assess memory, but again, you may pick up on memory issues. For example, if you tell them, well, I'm Tom, I'm going to be your nurse today, and then an hour later you come back in and they are saying, well, who are you, and what's your role here, and all that. So that may be when you pick up on memory issues. Emotional function, also known as affect. Affect is their expression, and is it appropriate to the situation or not? There may be, some people will have an inappropriate affect that's still, I mean, they may have a subtle emotional disorder or mental disorder, but it's not always necessarily a life-limiting one. Like there are people, for example, that giggle nervously, even in situations that call for expressions of sorrow. So that's not necessarily an abnormality. That could be within normal, but if it's but yeah, it bears looking into when they're expressing an emotion that's inappropriate for the situation. There are several issues that come up regarding substance abuse in daily nursing practice. One thing would be acute intoxication. It's not uncommon to have patients admitted because they're acutely intoxicated, whether it be with alcohol, drugs, or whatever. So the immediate problem is to prevent hazards of the acute intoxication. You think, oh, big deal, just let them sleep it off. But remember, they're at risk of aspiration, and I remember there have been rock stars, for example, that have choked on their vomit and died as a result of that. And also people can die of acute intoxication, so you don't want to just take it lightly. Then detecting patterns of substance abuse, that would be somebody that's in the hospital probably for some other reason, for, I don't know, maybe a GI issue, maybe for a surgery or whatever. And sometimes, for example, nighttime comes, they were fine all day, nighttime comes, they become increasingly agitated, and then after a while maybe they become a little bit tremulous, and when you did the initial assessment, why, perhaps they told you, oh, I just drink socially, at parties. And it turns out that they actually drink every day, and they start about 8 p.m. Say they start about 5 p.m. when their work is done, and they get drunk every night, and they're missing that. So this can come out in those kind of situations. And then what you probably need to do at that point is assess how much they really do drink, what their actual pattern of use is, and you probably need to get some medication ordered to help relieve that situation. In some cases, if it's not contraindicated, the physician will actually order a drink of alcohol. They may order, like 1 or 2 drinks. And if they do treat that as a medication, it would have to be given by the nurse. You have to watch them, document that it was given, and you give the amount that's ordered. A lot of times, because of especially if they're in with a GI issue, you can't do that. But you may be able to give a benzodiazepine, such as diazepam or chlordiazepam, one of those benzodiazepines. Prevention of substance abuse. We want to assess people that are at risk for it, and particularly and try to prevent them from developing substance abuse problems. One thing is looking at is age groups, and some age groups that are at high risk of substance abuse are people about your age, young adults, teens, young adults, and also older people. A lot of people, for example, do well through their working life, and then when they retire they develop substance abuse problems. So you want to try to prevent those kind of things from happening. Assess who's at risk, and one factor that puts a person at increased risk is if they're using a substance to meet emotional needs, like if they discover that alcohol or a drug makes them feel much more at ease in social situations, that it relieves their emotional pain, that this sort of thing, that's a danger sign that that person could be at risk for substance abuse problem. If you do detect a substance abuse problem, of course, we're non-judgmental. We don't want to come across as preaching at all, but we do want to offer resources. And it's fine if the person doesn't want, most of the time the person will maybe be angry even, but and maybe say, well, I don't need that. I'll save that for somebody that really needs it. But you've planted the seed, and maybe 5-10 years down the road it will bear fruit. Now, as far as the musculoskeletal assessment, you have to know normal in order to see what's abnormal. But if you do see something that looks abnormal, try to define it. Like, is it that their movement is within the normal, basic normal movement, but it's just not as, maybe they can only flex, maybe they can flex part way, but not the amount of degrees that they should. Or do they have a movement that's completely abnormal for that joint? Like maybe a joint that's only supposed to flex and extend, they can also do some other movement with it, or the movement itself goes in a different way. Then you want to define when you're documenting, especially, you want to be able to describe what it is that's abnormal. CMS, that stands for circulation, motion, and sensitivity. So CMS checks are very important after any kind of orthopedic injury or surgery. And you want to get the area distal to the part where the injury occurred or where the surgery was. Sometimes that can be a problem if the whole extremity is in a cast or something. It can be hard to get to it, but you want to get to the most distal, and you want to check for circulation. You check, of course, warmth. You can check capillary refill if you can get to a nail bed or something. But warmth, color. Then for motion, are they able to do the motion or not? Normal ranges in that distal area. You usually will have a cast or something immobilizing the area where the actual injury was, but you want to know if they're able to move parts distal to it. And then sensation, is there any tingling? Are they able to feel, first off? And then is there any numbness or tingling as well? If they do have an issue with any of these things, you want to compare it with what was going on before at the last check. Is the problem getting worse or not? One thing that you can do if you detect a problem, you can try, if you can elevate the extremity, that will many times that will take care of the problem. And many times when you detect a problem, like maybe the toes are numb, and so the leg is in a cast, so you elevate the leg, cast and all, on several pillows, and then you go back and look at your orders and you find that it was supposed to be elevated anyway. but elevating the extremity is one thing that will, and then you go back in an hour or so later and maybe the problem is resolved. But yeah, so elevating is one thing, and then applications of ice sometimes help as well. You would want, if you do use ice, you'd want that to go to the area where the swelling is, not to the area where, like, you aren't going to put the ice on the toes. You're going to be putting the ice where, on the area where the surgery was or the injury was. But of course that's usually with a cast or something, so you wouldn't have it direct. It may not be directly on that. And if it, you may need a physician's order to use ice. You're also going to be assessing strength, and remember that in the book it gives definitions for 5+, 4+, all those things, so read those definitions. Arthritis. Remember, we have two kinds of arthritis, rheumatoid and osteoarthritis. They have different symptoms, different expected findings, different assessment, findings, so know those. Then osteoporosis, you're mainly going to be concerned with risk factors and prevention for osteoporosis. Once you've got it, why, it's you're not going to be able to reverse it, but you want to look at risk factors and prevention there. Carpal tunnel syndrome, remember your Phelan and your Tinel test. And also that risk factors are important there. People that are at risk are people that do repetitive movements with their fingers, like typing, a lot of typing, using the keyboard on a computer, guitar playing, those kind of things. Scoliosis, again, that's especially with teenagers, that's important to screen for. And then the musculoskeletal system is closely related, or it's related to functional status. And by functional status, we mean a person's ability to care for her or himself. So are they able to do their activities of daily living by themselves? Do they need help? Do they do them by themselves with difficulty, etc.? That's important to assess, especially with older adults, but anyone with a musculoskeletal problem could have a functional status problem as well. Well, that's all for this video. I'll see you in the next module.